Hello, everybody. Welcome to our session today. I am Nee. I am going to be one of your co-hosts, and I will be going over a quick startup presentation to welcome everybody here and introduce you to our program and opportunities if you have previously attended our shadowing session. So, pre-health shadowing is a student-led, minority-led, and women-led nonprofit dedicated to helping prospective healthcare professionals gain access to educational resources, no matter their demographic status, abilities, or location. So I'm Annie, I'm the co-host, so thank you all for attending today. So let's get started. Just a little PSA, we do have closed captioning for all of our sessions to accommodate all students. This setting is available on the bottom of your Zoom screen. So if you need any assistance enabling the transcript, please direct message me or one of our lovely team members. We are always looking for ways to be more inclusive and ensure our sessions are accessible to everybody. So please, if you have recommendations for how we can improve, you can email us at info@prehealthshadowing.com. So since this is an international program, we want to know where you are Zooming from today. Drop it in the chat. I'm from Chicago, by the way, so yay. And so if you want to stay in the loop, follow us on social media. We are active on Instagram and TikTok, or you can sign up for our email list on our website so you can never ever miss a session, because why won't you want to do that? We all have some wonderful opportunities for you all as benefits of being part of our program. We have partnered with Kaplan. And so this is going to get you guys a 10% discount code that can be used on all Kaplan products, as well as free resources, such as study guides to help prepare you for standardized tests like the Mcat, NCLEX, or Pcat, any of those lovely standardized tests. If you fill out our short survey in the chat, you will get hooked up with this. So it's a great resource. So I recommend checking it out. We would also like to draw your attention to another amazing program called Neolith. Neolith is an online mental health platform for students. College and young adulthood is stressful enough, especially from yours truly here, as it is in the non-pandemic times. For pre-health shadowing professionals especially, we know the path is not easy. That's why we have partnered with Neolith to give you guys free access to their services. So if you use the link in the chat that is just entered by Aster, or enter the code PREHEALTH when signing up. Next, we have Mask for Mask. Mask for Mask is an amazing women-led organization, totally appropriate for Women's History Month, that donates 4 masks for every 4 masks sold. These go to people in need during the COVID-19 pandemic, those in the homeless community, health workers without proper PPE, or others who are struggling to stay safe. With our discount code PHS15, you can get a 15% off your order. If you buy through this method, pre-health shadowing will also get 10% off the proceeds, which is amazing because we are a nonprofit that runs solely off of the support and work of our students. Now, if you want to play a bigger part in supporting PHS, we would love for you to join our network of student volunteers and team members, like me. So you can apply to be a part of our administrative team and lead students in various projects, initiatives with professional outreach, grant writing, and so much more. We understand that as a pre-health student, you may not have the time, so we also offer the opportunity to volunteer asynchronously with tasks that can be done on your own time. We would love to have you be a part of this program and contribute your own unique perspective. Now, I'm not going to forget you high schoolers, you ambitious high schoolers. So if you are a high school student and want to get involved, we are starting a program called HTP, or High School Training for PHS, which allows you to connect with college pre-health programs, get involved in fundraising for PHS, and organize resources for other high school students interested in medicine through pre-health shadowing. So what are you waiting for? And we want to recognize the hard work of all of our students in the program. So if you are interested in getting published, you can submit essays, reflections, research papers, and reviews to our editor, chief, through the link dropped in the chat to have your work on our website. This will look great on CVs, applications, resumes, etc. So take advantage of this. Even in COVID, it's still doing great. So part of our mission at PHS is to promote diversity. So in order to do this, we have launched an initiative to have monthly panels to celebrate different demographics in the field of medicine. Some of these upcoming events include an all-female panel for Women's History Month, a COVID-19 roundtable, and an international student forum. If you have a mentor, professor, or professional that has inspired you, please think to contribute to these conversations. Nominate them today using the link in the chat. Now, we can humbly ask that you donate to our program. As I have said, pre-health shadowing is completely student-run, and we are working around the clock to keep this free and accessible to everybody. Unfortunately, Zoom and our website are not free. So any contribution you can give would be greatly appreciated. So if you're not financially able, we request that you send this link to somebody you think can contribute to support those who cannot afford similar opportunities. Throughout the session today, we encourage you to drop any questions you have for the speaker in the chat. Our team members will be making note of these to be asked later in the later half of the session. Now, if you want to, you can also use the raise hand chat function, and we will call on you to ask your question in person. Pretty brave. So take good notes as our professional is going over their presentation, as there will be the chance to take a post-shadowing assessment to verify your virtual shadowing hours. More information will be available on this at the end of the session, so please stay tuned. Lastly, if you can, we request you to turn your cameras on. This is by no means an obligation or any really strict professor asking you to do so, but we are respectful of different circumstances. But it does help us feel closer together in a time when socially distancing is mandatory. I am not the guest speaker for today. I appreciate you listening to the spiel, but I'm going to introduce you to our help speaker today. I would like to welcome Dr. Tran. Thank you so much for joining us today on this Wednesday afternoon. You may share your screen whenever you're ready. Take it away.
Unmute myself. Can you guys hear me? Okay, great. And you guys can hopefully see my screen. So thanks for coming
see your screen
today.
right now. Hang on. Try one
Sorry,
more time.
excuse me?
You can't see your screen right now. Try one more time.
Oh, wait, can you see it? Let me see. Okay, can you guys see it now?
No, we can hear you.
Oh no, wait, can you guys not see it?
No.
Okay, let me try again.
Yeah, come back to the Zoom session and then hit screen share again. Sorry.
No worries.
There you go.
Sorry about that, guys. Okay, great. Some technical difficulties. All right, so thanks guys for coming to my talk today. So my name is Ben Tran. I know that you guys are all very busy people, so thanks for coming out. Hopefully this talk will be helpful, talking a little bit about what the world of dermatology is like, what drew me to dermatology, and so let's get started. So this is just a brief outline of my discussion today. I'm going to talk a little bit about introduction for myself, talk about what is a field of dermatology, available fellowships that we have after dermatology, and then why I study derm in particular. I'm going to go over a few cases, just 3 of them, and try to make them a little bit more intense, kind of a little bit more engaging as well. And then talk a little bit about what I currently do during my prelim year, which is different than what I will be doing for dermatology for the rest of my life. And then just close with kind of the tips for students. So introduction for myself, my name is Ben Tran. I went to the University of Virginia for undergrad. I was a neuroscience major. And then I did a gap year. I was a scribe at Scribe America in orthopedics. And then I went to med school back at UVA again. Graduated pretty recently in 2020. I was AOA. I was on the admissions committee during my last year, which was a great experience. And then I'm currently doing internal medicine residency in San Francisco, and then I'll be going back to do dermatology residency in the Washington, DC area. Just as a side note, I'm the CEO and founder of ShadowDoc. So if you're interested, you can find us on Instagram, or you can find me on Instagram at Dr. Tran. So just a disclaimer, all these thoughts and all these discussion points are just of my own opinion. They're not affiliated with any academic institution or any medical admissions process. I do not have any financial disclosures. And unfortunately, sometimes skin can be really graphic. So I'm definitely going to give any forewarning if there's going to be a graphic image, just in case people are a little bit more sensitive to that. So just going a few definitions. What is the field of dermatology, and what are some example skin conditions that we do see? So according to the AMA, dermatology is the diagnosis and treatment of benign and malignant disorders of the skin, mucous membranes, hair, and nails. So it's important to just note that it's not just the skin that we take care of. It's also the mucous membranes, including the lips. It can go from the hair all the way down to your toes. So this is just an example of that. Like I said, we cover everything from the scalp all the way down to the toes. These are just some example conditions. So alopecia areata is focal hair loss, commonly affecting the scalp, can affect anywhere else on the bearded area as well. Obviously, we treat acne. I feel like that's probably where dermatology get their kind of bread and butter. And then there's tinea pedis, which is just like a fungal infection of the feet. So why go into dermatology? I think that this is something that is not as commonly discussed. And I think it's weird because I never really had any exposure to derm until like college. And before that, I was just like, oh, it's just some weird rashes and stuff like that. Most of the introduction that I did get was just kind of from my perception of media. So this is a classic scene from Grey's Anatomy. I actually never watched this show very much, despite it coming out when I was like in high school. But I saw this scene after I decided to pursue derm. And in this scene, like Meredith Grey and Christina go up to the dermatology clinic and they see that residents are getting their nails done and having like a great life, whereas like they're very miserable during their residency. And this just goes to show how dermatology is perceived in pop culture. Is perceived as a very lax and kind of laid back work environment, which it is, but definitely something to note that a lot of people end up pursuing derm, maybe not for the right reasons, particularly if they want a good lifestyle. We don't get our nails done every single time in the clinic, and I think that'd be really distracting. But maybe it might be good, but not for me. So it's good to make sure that you're going into dermatology in your ultimate specialty for the right reasons. And so just a few reasons why I find dermatology really interesting. So I think it's really great for people who are visually oriented. So I learned great from looking at graphs, making my own charts, making my own pictures and kind of diagrams and flow sheets. And so it's really great for those that like those sorts of things. Whenever we go into clinic, we're able to kind of look at the lesion or look at a rash and say, based off our pattern recognition, like this is what it is. It's really nice because sometimes you don't even have to rely on the patient's history, or sometimes the patient's like, oh, maybe I may have done this, may have done that, and they're not the great historian. So it's really useful for us to be able to look at it and be experts in diagnosis. And the next thing is that it's really great for hands-on kind of experiences. So dermatology, not only do we treat and look at lesions themselves, but we also do a variety of surgeries, excisions, and suturing. And this can be done in the clinic. It doesn't necessarily have to be scheduled in an OR, and patients are very hesitant, very fearful of those sorts of experiences, but it allows us to have diversity in our day so that we're not just, looking at rashes and then just prescribing a medication, but we can also be doing a minor procedure in one room and then go back and treat another skin condition. Examples of this is Mohs surgery, cosmetics as well. Dr. Pimple Popper has kind of made that very, very popular. And then last but certainly not least, dermatology is very rewarding. So it feels really great for me personally to be able to help others feel, confident and happy in their own skin. Unfortunately, society places a lot of emphasis on kind of the external appearance of individuals these days. And so it's really difficult for those sorts of patients that have chronic skin conditions that feel kind of criticized by society. And so being able to help them and develop those long-term relationships, treating patients that have those conditions, seeing them every year and seeing them grow and be more confident in their skin is really rewarding. And so this is kind of my general path to derm. Everyone's path to their own specialty is different. This is mine. So I took a gap year as an orthopedic scribe. I entered medical school. I was very gung-ho about either orthopedics or neurosurgery. Then came along third year, and that's typically where we make this decision of surgery or not to surgery. So surgery or medicine, to cut or not to cut. For me, I ultimately was deciding between plastics and dermatology. They're both very skin oriented, and it's a lot of fun in the operating room being able to use your creative mind to figure out like, where should I take this flap or take this part of the skin and flap it over. But ultimately for me, I really valued the patient relationships the most. In plastics, I found that a lot of times the surgeon would meet with the patient, do a pre-op visit, do the surgery, and then do a few post-op visits, and then kind of release them. But in dermatology, we're able to follow them long-term, like as I mentioned before. And then after that, I got more involved in derm research. So it includes a condition, Stevens-Johnson syndrome, which I'll cover. I got really interested in wounds and the use of artificial intelligence. And I found that there's a lot of technological advances that we can use. For example, like Stanford has been coming out with a lot of research and using AI to be able to diagnose like melanomas, skin cancers, just as well as dermatologists have, which are scary for us, but also really cool and innovative. So this is a typical Durham timeline in the US, at least for students. And so typically we go through medical school, which is 4 years. You could do a research year plus or minus 1 year, and then go through residency. The first year residency is kind of a internal medicine or surgery, general training for how to be a doctor. And then after that, we subspecialize into dermatology for 3 years. And then the total of that is 8 years. And then fellowship can be anywhere from 1 year to 2 years, and then we're finally done. So after 9 or 8 years of training, we're finally attending, practicing independently, and doing whatever we like to do as a specialist. So these are a variety of fellowships that we have after Durham residency. There's a lot of them, just to cover a few. So Mohs surgery is when we're able to be the most complex surgeon in Durham, doing very, very complex flaps and reconstructions. And we're also a pathologist. And so we're able to look at skin tissue underneath the slides and make a definitive diagnosis. There's obviously cosmetics. We can do Botox, fillers, lasers. Pediatrics as well. You can look at eczema, congenital conditions. Derm path is similar to Mohs, but mostly just the pathology side. So you're mostly looking underneath the microscope. There's one specialty just for lasers themselves, just because they're such an innovative field nowadays, including pulse dye lasers, Fraxels. And then lastly, there's complex. And so these patients tend to have the most more comorbidities. They tend to be very complex. They interface with a lot of other medical specialties such as infectious disease and rheumatology. And it's really rewarding being able to take care of these patients because you have to really use a lot of mental fortitude to figure that all out. So that's all kind of just like the logistics of derm. So going through kind of the terminology and how we talk about dermatology. A lot of derm, as I mentioned, is really visual. So we have a lot of fancy words to describe what we're seeing. This was before the advent of technology. So before you could just take a picture and send it off to your friend, just be like, what do you think this is? So here we typically describe lesions based off of size, color, shape, and secondary changes. So the size, for simplicity's sake, can either be small or large. We typically measure it. And then for color, it could be salmon pink, which brings to mind certain diagnoses for us. Tan brown, the shape could be flat or raised, and then secondary changes. So like, what are things that are going on top of the skin other than the primary lesion? And this is just a graphical depiction of that. So for example, I already described what a macule was. It's just a flat lesion. So if you ran your finger over this, you would say that it's a flat macule, or just a macule that's tan brown, ovoid. And then if you compare that to a papule, this is a raised lesion. And so it seems like a lot of different kind of language to describe very similar things, for example, like this versus this, but this is a plaque because it's raised, whereas this is just a macule. And it's important to be able to distinguish these whenever we're dermatologists, because lesions have very characteristic appearances. And so we can look at or hear a description of a lesion, say like yes, this is exactly what we were hearing, because whenever we hear about a wheal, we typically think of like allergic reactions, for example, and we think of petechiae and purpura, we think of like vascular lesions, just given its appearance and everything like that. So it's important to have this kind of as a really good skill in dermatology. And then as a dermatologist, we have a variety of different treatments and also tools that we use. Unfortunately, in dermatology, we don't have a stethoscope, but what we do have is a dermatoscope. So it's essentially a really high-powered magnifying glass that we kind of carry in our pocket. It has a polarizing light ability, so in case that some lesions demonstrate different characteristics with polarized light. And so we're able to, sometimes we're able to attach it to our phones if we have that sort of that apparatus, but a lot of times it's like what we see here, and we're able to take a look at it underneath the dermatoscope, which I'll show a picture of later on. And this is where a lot of the AI has been coming involved in, and taking a look at these dermatoscopic images and being able to diagnose the lesion. And then for our treatments, we typically rely heavily on corticosteroids. They could be available in topical form. They could be done in oral form. Hydrocortisone is a great example. Typically, those are just over the counter. It can be used for minor injuries, bug bites, etc. We could get a little bit more advanced and use lasers. We obviously have hands-on treatments, as I mentioned before, biopsies, surgeries. And we also have oral immunosuppressants, which are a little bit on the more advanced side, commonly used in like complex derm, and then antibiotics and fillers. So that's a lot about all of just kind of the logistics and kind of introduction to derm. So I think it's a little bit more useful to see them in kind of clinical context. So going through the cases here, this is a 30-year-old female. She presents with a mole. She noticed on her right lower leg, presented about a year ago. It's getting larger, it's not painful. And then she shows it to you. And this is what we see here. So these images aren't my own personal images. They're all taken off of dermnz.org. So sometimes it doesn't correlate with the age, for example, but just for example's sake. So here we can see that there is this lesion based off of the lower posterior lower extremity. And then this is a dermoscopy image. And so we're able to see based off of here, we could see some kind of tan brown / black confluations or differences in the color throughout. And it's useful because based off of this lesion, we were able to tell what kind of webbing they have off of different dermoscopy, and it's different for different types of lesions. And so for our example, our exam and how we would describe this lesion is a 1 centimeter asymmetric dark black macule, which means it's flat. And then it has a raised papule within it. And then there's a lot of color variation. So that description, if you say that to any sort of dermatologist, kind of raises some warning signs, and we kind of think about what we would have already. So what are you concerned about? And so this is our first poll question. Are we concerned about a squamous cell carcinoma, B, a basal cell carcinoma, C, melanoma, or D, just some rash? And so I don't expect everyone to know the answer to this, but just to get a survey of what everyone thinks. I actually don't know how to do this, so whoever is helping me can help. Oops, sorry.
Feel free to drop your answers in the chat. I think we have one person saying melanoma, or a couple people saying melanoma.
Great. All right, give it a few more seconds. Sweet. Seems like mostly everyone has responded. So it seems like an overwhelming majority has said C, so we'll see what the answer is. So for this patient, the next step before we even get to the diagnosis, we kind of had a high clinical suspicion based off of our physical exam, but oftentimes we need a definitive diagnosis. And that's very commonly where our derm pathologists come into handy. And so we need to take a sample of the tissue. And so the best way to do that, there are a variety of ways, but there's shave excisions, there's shave biopsies, excisions, and then there's punch biopsies. These are just varieties of ways of taking out the skin. Punch biopsies can go deeper into the skin, whereas shaves, as I'll demonstrate here, are very superficial. And then excisions are when you completely remove the lesion itself by surgery or kind of minor operation. So here we have a demonstration of what would be a shave biopsy. We do local anesthetic to the site of the lesion. This is not the same lesion. But then we take this blade that is curved, and we're able to use our manual dexterity to kind of take a small sample, whether it's shaving a little bit off the the top or going scooper and going a little bit deeper. And from this, we're able to then send it off to a dermatopathologist and they'll give us a read. And so this is what they would say for our patient, for example. This would be a malignant overgrowth of melanocytes. And so melanocytes are these cells that are found at the base of the epidermis, which are the top layer of the skin. They're the melanin producing cells. And so an atypical overgrowth, as you can see in these little clusters, typically there's only like one or two like per few of these little inlets. But for this patient, we found multiple of them. And so this is really concerning for actually a melanoma. And so for these melanomas, just based off of physical exam alone, we can often have a high suspicion. And so the few things that we remember as dermatologists are the A, B, C, D, E's. And so this is, this is A for asymmetry. So whether or not the lesion is symmetrical or asymmetrical, and then B for borders. Are they even? Are they uneven? And then C, color. So what is the color variation? Is it the same color throughout, or is it different? And so for our patient, if you remember, had a color variation within the lesion. And then the diameter. So this is commonly, is it just bigger or smaller than the edge of a pencil eraser? So that's 1/4 inch. And then lastly, is the lesion actually getting larger? So our patient met all of those kind of criteria, which is concerning for us that she may have an underlying melanoma there. And on definitive diagnosis on dermoscopy and dermatopathology, we found that she did. So there's a few risk factors for early melanomas, particularly early, meaning that it's an early age. So females have a higher risk. Lower extremity also tends to be the site of occurrence. Sun exposure, so history of sun exposure, particularly tanning beds are very notorious for causing melanomas even at a young age. And then many moles at baseline. And so that is also a risk factor. And then, so why is it important? This is amongst dermatologists, melanoma is the highest mortality of all skin cancers. It causes about 9,000 deaths per year, according to the CDC. And there's a high risk of metastasis. So that's really where the major concern is. So this is just a brain MRI image of a patient that has a melanoma, probably developed some sort of neurologic symptoms, and then did an MRI. And we could see here in the scan and then on the subsequent flare that there's these metastatic lesions. And so this is melanoma that has gone to the brain. And at that point, it's very difficult to cure and to treat. So it's definitely a worrisome finding whenever we think of melanoma. And then, as I mentioned, a lot of patients sometimes have only one mole or they have multiple. And so it's easy whenever you just have one mole, but when you have this patient that comes in, he says, I have a family history of melanoma. And then you're starting to think, oh my gosh, like, where do I even start with these? And so it's kind of gotten to the point where it's just like, oh my gosh, where's Waldo? And so it's really hard to find the melanoma sometimes, but it's great practice. And there's some individuals who are pigment lesion experts, so they only focus on melanoma. Right now, there's been this new invention or kind of developments of what we call total body mapping, or like mole mapping. And so the patient would actually stand in a room and there's like 360 cameras. And so they're able to take a whole body image of the patient's moles and to track them over years to see if there's any enlargements of any particular moles. But this can be really concerning and scary as a dermatologist. So for the treatment, there's a variety of treatment options. Depends on the particular lesion. For melanoma, since they're so aggressive, we tend to be a little bit more aggressive in how much skin we remove around it, which is difficult because our patient fortunately has a lesion on the leg, which is easy to take care of. But if she had a lesion on the mouth, or if she had a lesion on her face, taking that much excessive skin can be really cosmetically damaging. So it's important to be able to do the procedure and to take that melanoma out without leaving too big of a scar defect. And so this is where micrographic Mohs comes into handy. So Mohs is a specialized type of dermatologic surgery in which we're able to remove the smallest amount of skin without leaving any cancerous cells behind. And so the premise behind it is that, let's say that we have a skin cancer here. This, as you can see, or maybe not see as well based off of the depiction, that there's actually skin cancer that is going further deeper. It's kind of like the tip of the iceberg that goes further deeper. And so on a superficial level, when we're looking on the outside, we can't just take a wide scoop and just say, we've gotten all the cancer out, but as a result, we've taken so much of the skin that there's a large defect there. So Mohs is a way that we're able to take the first slice and just remove the first layer. And then we take this slice and we go directly to the microscope and we say, from where else is the cancer progressing? So is it going further down? Is it going to the further left or further right? And so from there, we'd be able to go back to the patient who's still there, and then we'd be able to take another section. And so we repeat this process over and over until we're able to take the smallest amount of skin going down further to remove the cancer without leaving the biggest defect. So just an example of this is a patient that came in with a melanoma in situ, which means that hasn't gone past the basal layer, but there's a lesion here. It's very close to the fold of the nose. So in a typical surgery, we would actually have to remove like almost all the way out to the nose. And that's really cosmetically disfiguring. So Mohs would be able to just take the first section, and then it's nice because we can see in the second image that they probably have found that there's cancerous cells that are extending beyond this way. So they took a larger section here. And then after that, they found that this is all that they needed to do. They didn't need to actually cut all the way out to the nose, which is really nice. And then you're able to just do like a primary closure, do a few stitches, and then you would be able to hopefully line it up with the nasal fold. And so it looks pretty good cosmetically afterwards. So that's case one. You can feel free to drop any questions in the chat box about that one, but I'll move on to case number two. So this is a little bit different. This is a 25-year-old male, presents to the clinic. He has several months of some weird rash on his back. It's been getting worse, and he's been going to the pool thinking that maybe it's due to the pool. He notes that summer just started a few weeks ago, so he's been really outdoors a lot more. And this is what it looks like. And so here we can see that there's, it's hard sometimes to distinguish what is native skin versus what is the quote unquote pathologic skin or the disease skin. So for this patient, we would see that there are several ovoid light brown hypopigmented macules coalescing into patches on the back, which is just a fancy way of saying we have some small little white spots that are getting bigger and bigger and grouping together to form this large white spot on his back. And then, so what do you think the cause is here? Is it A, a fungal infection, B, autoimmune destruction of pigment producing cells, C, suntan reaction to pool products, or D, early developing lupus?
So I figured out how the poll feature works. So feel free to answer the poll that's up now with what you think the cause is. And looks like we got a wide variety of answers coming in. To give it about 10 more seconds, you got about half the people voting right now. This is anonymous, so it's not like it's going to be linked to your name. Feel free to give it your best guess. Okay, here we go. So many people saying autoimmune destruction of pigment producing cells.
Great, we have a pretty good spread. So let's see what he actually has. So we actually do something at bedside, which is called Wood's lamp. And so there's a variety of different ways to diagnose lesions. We don't always need to take it out. And so a Wood's lamp is a useful kind of tool. It's like a UV light kind of ray. We just shine it on the lesion, and we see that it's commonly used to detect fungal infections, as well as to detect vitiligo, which I'll discuss. But on fungus, the lesion will actually shine like a yellowish green. And so this isn't our patient exactly, but for example, they would actually look like this. And so you can see it's like it doesn't project very well, but this would actually be a yellowish green in person. So this is actually consistent with what we would think is a fungal infection. So this patient actually has psoriasis versicolor being a variety of colors within the lesion. And so the etiology is actually a skin fungal infection. It's caused by a Malassezia species, which produce chemicals and impairs the melanocytes, which I discussed before. The risk factors are young adults. They tend to be in humid, temperate locations. Typically, whenever you see it, sometimes you commonly see it at the pool. If someone has different kind of like rain dew drop spots, you would think like, oh, like what is that? But it's just a simple fungal infection that is pretty easily treated. So the diagnosis could be at bedside via Wood's lamp, or it could be also via a KOH stain. And so this is just an example. We would actually take a scraping. So just take a little blade, scrape against the skin, not enough to draw blood by any means, and then put it on a slide, look at it underneath the microscope. And we see that there's a variety of things that we see. So first, we see that there's these kind of balls, a little fungus, and then they also have these extensions of hyphae up. And so we describe this as a classic meatball and spaghetti kind of appearance. And this is very typical of pityriasis versicolor. And it's important not to get it confused with vitiligo, which is what most people have chosen. So that's the autoimmune destruction of pigment producing cells. It's also popular because of Michael Jackson has that condition as well. And so you could see here that it's really easy to make the confusion between pityriasis versicolor versus vitiligo, but the treatments are very drastically different, and also the prognosis can be very different, whether or not it'll go away or whether or not it will recur. So it's important to make use of the tools that we do have to be able to tell what kind of lesion it is. And then for pityriasis versicolor, the treatment's actually pretty simple. We just use antifungal shampoos, tends to go away in a few weeks. And then if you continue to use a shampoo, it'll continue to remain away. So it's good and important to be able to distinguish the two. Okay, third and last case. So this case is a little bit more intense. The other two cases were classic cases we'd see in the office. This type of case is what drew me to derm in particular, just because I had a plastic surgery interest. So we have a 50-year-old male. He presents to the emergency room. He has diffuse total back pain, noticed some bubbles forming on his neck and his back. He just started taking Bactrim, which is the generic name is trimethoprim sulfamethoxazole, but it's basically just an antibiotic, and it's used, he's treating an infection. So in the ED, he's febrile, he has a fever, he has low blood pressure, he looks acutely ill, just looks kind of sick overall. And so just a forewarning that some of these pictures may be graphic, just in case people are sensitive to that, just to be aware. So taking a look, so here we have a picture of his neck. You can see that there are some bulla that are forming, or there is some fluid-filled things on his neck and some developing on his chest. And then, so this isn't too dramatic of a finding, but if we take a look at his back, we see that it's completely red, and that if we actually were to run our finger over it, we see that the skin actually just slides off. And so this is really worrisome to a dermatologist whenever we see these sort of physical findings, because that shows us that the top layer of the skin has actually separated from the bottom layer, and that there's structural damage there, and can be really harrowing or indicative of something that's coming. And so we call this a positive Mikulski sign, whenever we're able to just run our finger over and then the skin kind of just sloughs off. And so the patient is kept in the ED. He's observed for the next few hours just to see what develops. And then he suddenly has worsening fevers, pain, dropping blood pressures even further. And then we do a repeat skin exam. And some of these images may be graphic. So we see that starting from the head to toe kind of scan, we see that in his eyes, he's complaining of blurry vision, he's complaining of almost near blindness, and we see that he's having some erythema or some redness in the eyes. And then if we take a look at his mouth, we're seeing that he's starting to develop these hemorrhagic crusts, and he's starting to bleed from the mouth. He's starting to have difficulty with swallowing, and sometimes often have difficulty with breathing if they affect the posterior throat. And then if we look at his back, we saw that what we had before was just complete redness, but now we have complete separation of the top layer of the skin from the bottom layer of the skin. And he's starting to look very, very sick. We see progression of the rash even beyond that, just the redness, so that extends beyond further down onto the back. So based off of all of that, where would you want to treat this patient? Should you switch him over to the general medicine floor, send him directly to the operating room, the dermatology office, or should we send him to the burn unit from the ED?
Feel free to put your answer in the poll that I just launched. Ooh, it's gonna be interesting. Yeah, that a 50-50 split between two answers here. Give about 10 more seconds. So these aren't linked to your name at all, so it's just fun to see what we think so far. All right, on the poll now, and okay, about 50-50 split between operating and burn unit, with operating room winning out ever so slightly.
Gotcha. All right, let's see what the answer would be. So this patient actually has the condition that I mentioned, which is Stevens-Johnson syndrome. And we're not entirely so sure why it happens, but essentially it's very common after a patient takes some sort of drug, some sort of antibiotic or anything, and then develops a severe drug reaction. And so the most common types of pills are associated with it are antibiotics, actually, including penicillins, Bactrim, anti-seizure meds, lamotrigine, and then NSAIDs, which is just like a typical ibuprofen. And so this is just a warning that, a lot of the medications that we do give as doctors have side effects. And it's not just like, oh, take this simple pill and everything will get better. But just be aware of any sort of medications that you do give, and be aware of monitoring for any significant side effects that may occur. And so the diagnosis for this is typically based off of history, just kind of getting a really important history, what kind of medications they took, what kind of exposures they may have had to drugs, and then doing your exam. So looking to see if there's a positive Mikulski sign, as I mentioned before. Oftentimes these patients do get biopsied as well, just to make sure that there's a definitive diagnosis that we could put on the books. And then it's important because like similar to vitiligo and similar to many things in derm, all rashes kind of look the same. Like this patient's rash, when she first came in as well, could be very similar to Stephen Johnson's. It could be very concerning if you see this rash all of a sudden, you're like, oh my gosh, this is going to get much worse. But not all drug reactions are SJS. Some of them just come and then they go if you take away the antibiotic. Penicillin is a very classic example of that. So for the treatment, SJS has such a high risk of death just due to infection. It can also cause kidney failure, it could cause lung failure. It commonly puts people into shock, whether it's hypovolemic or septic shock. And then oftentimes patients can develop blindness because it affects the eyes as well. So the treatment for this patient would be immediate fluid resuscitation, giving them as much fluids as possible, stop the offending drug, going through their drug history. Most commonly, it could be easily identified, or sometimes it's not as easily identified. And then this patient would most likely be transferred to the ICU or the burn unit. Those tend to be the best places. And from what I found, what was interesting coming from plastic surgery initially was that I thought that it'd be really cool if you were able to take skin from unaffected areas and then place it back on the places that would be affected, such as a skin graft, and that would take them to the OR. But actually, there is very limited data in that sort of treatment. And oftentimes that actually leads to even poorer outcomes, because then you cause two sites of wounds. And the first site that you tried to replace the skin is still completely affected and completely diseased, that won't be able to heal despite trying to put another layer of skin that's healthy on top of it. And then some steroids have been studied, but haven't actually been really strong in the support of the data. So that's all great. And that's really nice to talk about what I actually would do in dermatology, but I'm just going to conclude a little bit about what I currently do. So now I am a current first year intern in internal medicine. And so it's a little bit different than what my days in dermatology look like. I've definitely done a lot of derm already in med school, and so I have a great grasp of that. But I could talk a little bit about what I do now. So right now I'm an internal medicine prelim or intern. So you can either do internal medicine, you can do surgery, or you could do pediatrics. For me, I wanted to do internal medicine because I felt like it gave me the best sense of what a person's like overall general health, like listening to their heart, listening to their lungs, and being able to understand skin and the entire context of the patient. So on the wards, I typically work anywhere from 7 a.m. to 4 p.m., work 6 days a week. I also treat a variety of different conditions: congestive heart failure, COPD exacerbation, smoker lung, pneumonia, sepsis, a variety of the different things. And then in the ICU, which I'm typically on as well, I work 6 a.m. to 5 p.m., 6 days a week. We take care of the entire ICU patients. And so these patients can be intubated, reliant on breathing tubes. They could be on multiple pressors to support their blood pressure, to keep them alive, or to even keep their heart rate up. But throughout the day, we're actually interrupted. If someone has heart stops throughout the entire hospital, we call it a code, and then the entire ICU team runs up and rushes to go to CPR and to get the patient back. And obviously during these past few months, I've been treating a lot of COVID patients that are intubated and sedated in the ICU, and often some of our sickest patients that we take care of. And then I also did a few weeks in the ED, just reviewing how to take care of patients with strokes, heart attacks, mass casualty events, including like motor vehicle accidents, etc. And so we can always ask questions about this as well. It's just a pathway, a little part of the pathway to derm, but certainly along the way. So this is just a few tips for students based off of where you are currently. In high school, it's I think the best and most important thing is to just do well in the classes that you currently have. It's easy to say that, but it's important because it helps you to pursue your college of choice, wherever you'd like to go. The other thing is that you can consider doing a BS MD degree if you are coming out of high school. So those are combined programs in which you're able to go through college and med school at the same time. Oftentimes you don't even need to take an Mcat, and it's really nice because it can be accelerated. So you don't actually have to take 8 years, you do 7 years, for example. And then if you're a college student, I think it's really important to focus on your academics. I will make a side part here that you don't actually always necessarily need to major in a science. You can major in whatever you like, as long as you're passionate about it and as long as you complete your prereqs. But in terms of your academics, the Mcat is an important thing, unfortunately. So just try your best on that. If your school has Phi Beta Kappa, which is an honor society, try to get that as well. Sometimes admissions committees look at that. Shadow, if you can. I know it's very difficult nowadays, unfortunately, just due to COVID. But even if you could do it virtually, hopefully, then it still helps, and it shows that you're interested, and it shows that you're taking initiative rather than just kind of waiting for things to get better. Volunteer as well. It just doesn't necessarily need to be in a medical field. A lot of times I advise my mentees that they can do any sort of thing that they're passionate about, whether it's walking dogs or if they like really volunteering at the art museum. Just doing something can be really nice, and it makes you stand out whenever we actually do interview you on the admissions committees. And then research doesn't necessarily need to be in dermatology. If you're in college, feel free to do any sort of research as long as it interests you and you can talk about it passionately whenever you do interview. For volunteering experiences specifically related to dermatology, there tend to be a few. If you could reach out to your neighboring hospital or your neighboring dermatologist office, maybe they do have some volunteer activities such as like sun cancer screening like events that you can volunteer at. And then for students interested in taking a gap year or bridge year, medical assistants or medical scribe jobs are pretty prevalent now, and they're helpful for me, at least when I was a scribe. So in conclusion, derm can be exciting. There's great patient care experiences. You're an expert in like skin and diagnosis and treatment. There's a wide range of technical advances, as I mentioned before, artificial intelligence, dermoscopy. There's confocal microscopy as well. There's definitely a component of lifestyle, so it's very nice to have time to do other things that you'd like. And dermatology is unfortunately one of the most competitive specialties there is. So study smart, not just hard, and best of luck. So I'll take any questions.
Thank you so much, Dr. Tran. This is a wonderful presentation. I'm just going to launch one final poll before we get into questions here about what we thought about this presentation. Does this presentation make you want to pursue dermatology? Also, again, no names are attached to this. It's just cool to see where we're at right now.
Please answer truthfully.
Yes. Yeah. And so we got a lot of questions in the chat, so we'll get right into it. I'll also open it up to any of our students here. If you want to come off mic and ask your questions directly to Dr. Tran, feel free to use the raise your hand feature. I believe it's in the reactions button down below, and we will help facilitate that connection so you can ask your question. All right, cool. We got, again, around a 50-50 split with a couple more people saying yes. Okay, and so I'll get right into questions here. Let me see where we're at. Okay, so Rihanna asks, what are some misconceptions of working in dermatology or being a dermatologist that you didn't know before going into the field?
Yeah, I think that probably one of the biggest misconceptions is that we have like a very easy life, and it's like very, very easy to have the dermatologist lifestyle. And that's why we're typically associated with the road specialties. So in medical school, there's like the road to happiness or the road to life specialties. It's an acronym that's like radiology, ophthalmology, A for anesthesiology, and D for derm. But it's actually not the case. And dermatology can be very stressful in that we take care of a lot of patients. We sometimes see like 60 patients a day or 40 patients in a day. And it can be really, really overwhelming whenever you're actually doing it. And unless you're very engaging and take a lot of energy to engage with people, it can be really draining emotionally and socially. And so that's probably one of the biggest things. And then the other thing is that's a pretty common misconception is that we only focus on the skin. So as I mentioned before, we do a lot of things on different areas, including the scalp. And there's some people who actually do hair transplants. And so there's a variety of different skin conditions that we do treat in derm.
Thank you for that insight. Well, Aster has asked us, how do you compare skin conditions and apply these differentials to varying skin tones?
Yeah, so that's a great question. And there's been this new movement in terms of dermatology and skin of color. And it's very unfortunate that a lot of the studies that we do have and a lot of pictures and education books that we have are on typically Caucasian individuals. And so we all are starting to realize that diseases and skin presentations are very different on skin of color. So something that may be red on one patient may actually be brown on a different patient. And so there's been a large movement in that, and a lot of the education textbooks and a lot of our education is trying to demonstrate and emphasize the difference so that we're able to recognize it in our presentations.
Nice. And on that note, Angel asks, how are you able to distinguish the difference between fungal infection versus vitiligo? Would it just be using through wood lamp, or is there other methods?
Yeah, so there is definitely the Woods lamp method. And so I forgot to mention that on a Woods lamp, as I mentioned, fungal infections appear yellowish green. And then if you actually take a look at it underneath for vitiligo, it looks pure white or actually blue-white. So you're able to distinguish it off of that. And then if you're unable to distinguish it completely, you're able to just take a small skin sample. And so that's one of the best things about derm is that if you're really unsure about your diagnosis, you can always take a small skin sample, unless it's on the face and you have to be very cosmetically sensitive. But that's one of the reassuring things about derm.
Going off the topic of like looking at the skin, Rihanna has asked, how did dermatology function or work before the invention of the dermatoscope? She feels like it would have been hard to see the subtle changes before that.
Yeah, so I think that unfortunately we may have just practiced a little bit more crudely. It may be more reliant on taking skin samples, whereas now we're able to use a dermatoscope. There's the field of dermoscopy is actually growing. Since it's so new, we're still finding subtle changes that we're able to detect based off of that. And there's even this new technology like confocal microscopy, which is typically used in like a wet lab. But we're able to even take that and look at directly at a skin lesion and see if there's cancerous cells. And so you could take a look at that as well. But before dermoscopy, I'm not entirely so sure. It's also before my time. So.
Yeah, that sounds a little scary to hear about the olden days before. I'm glad technology is advancing. Another question we had also from Rihanna was, do melanomas appear the same in most people, or do they appear differently as the skin type gets darker?
I think that they most commonly appear differently in different skin types. The ABCDEs tend to hold true for any sort of patient though, regardless, because if there's still color variation within the lesion, regardless of the native skin, it typically will still demonstrate color variation that we can pick up as a dermatologist and be able to say that this is a melanoma. But certainly, as I mentioned before, something that we're making sure that we're trying to be mindful of how the lesions appear differently.
So I'm going to ask another question from Rihanna, and I'm pretty sure she wants to be a dermatologist like you one day. So she also asked, have you ever seen a metastatic melanoma or a more complicated skin cancer case?
Yeah, unfortunately, I've seen some really complex skin cancer cases. There's patients that, for one reason or another, don't actually want to come to the doctor. I mean, I personally don't even like going to the doctor despite being one. But we had a patient that came in and he had this like huge fungating mass, and it was essentially eating away into his eyeball. So he was losing vision, and that's really what prompted it to come in. So if you can imagine just like this large cancer just taking up half this guy's face. And at that point, it's almost impossible to cure. And so it's really unfortunate whenever we see those sorts of cases, because what we can do is just salvage therapy. And so we could try to salvage his vision, but at the same time, most often than not, they tend to pass away. And so metastatic lesions tend to be very scary, particularly if they're melanomas.
That does sound really scary and hard to treat when you see it. Tom asks, if a patient has melanoma, especially the cancerous kind, do dermatologists perform the treatment by themselves, or do they also work with an oncologist?
Yeah, it's a great question. So it depends if there's actually spread beyond just the skin. So if it's within the skin, we're able to just do a local resection ourselves. Oftentimes, they don't even need referral to oncologist because it's just a primary lesion, hasn't metastasized, so there's no concern. If it's metastasized to a lymph node, for example, that's typically when we start working with our medical oncologist. Or there's also dermatologists that focus particularly on oncology for melanomas. And that's when we're starting to use like pembrolizumab, which is one of the anti-melanoma agents. And we're using like immunotherapies nowadays. And so that's when we start to get involved and kind of help along with that. So it's a very cohesive, sometimes we're very cohesive in that we work a lot with our medical oncologists and melanoma.
Another audience member named Leslie has asked, do dermatologists work patients that have extreme skin allergic reactions?
Yeah, so that's a very common thing that we typically see in dermatology, particularly for eczema patients, actually, is that a lot of patients will report that they have an outbreak of eczema if they are associated with some certain type of foods. So we do work with them, and we try to identify what other type of foods may be causing it. Oftentimes, based off the literature, sometimes food isn't always the main trigger. Most of the times it could be moisture or something like that. There's one condition that we call like chronic urticaria, which is essentially just chronic wheals. So like just like itchy spots after a bug bite, and it just occurs throughout your entire body. And so that's what we often treat as well. And it's just a variety of different antihistamines. If anyone's interested, they can also look up like dermatographism. And so if you make a scratch on someone's skin and you write like do a crisscross on someone's back, it'll actually just show up as a large crisscross as a wheal. And so those patients tend to be more prone to skin irritation and have that come up as well.
Interesting to hear. Tessia Saez, sorry if I pronounced your name wrong. They asked, I have two friends that are from Puerto Rico and they have the same white spots that you showed in the presentation, spreading from their shoulder to their hands. Is that normal for people who live in Hispanic Caribbean countries?
As I mentioned before, it tends to be in countries that are much more temperate climates. And so a lot of countries along the border, or not along the border, but the equator tend to have these sorts of things just based off of the humidity there. So I'm not a dermatologist yet, but I would recommend your friend to see one if they would like to get that taken care of. It may not even be psoriasis versicolor. So yeah.
Saez has asked another question, and they wanted to know, I wanted to go to a medical school outside of the US. Is that frowned upon, or is any medical school accepted to become a dermatologist?
So it's a good question. I think that it depends on what the specialty you would like to go into is. So unfortunately, just given how competitive dermatology is, a lot of times international students tend to have a very difficult time getting into dermatology. Not that it's impossible by any means, we've seen it happen, it occurs, but a lot of times students tend to find it really hard. And I would recommend that students explore all their different options that they may have, whether or not it's in the US or whether or not it's in Canada or vice versa or international. But regardless of wherever you go, just be the best student that you can be. Try to find research opportunities that you have. Step one will be pass fail soon, as I saw someone mention in the chat. And so that changes the dynamics a little bit. But unfortunately, it doesn't change it that much because now we're just going to be reliant on step two, which is just an exam that's taken subsequently later. But it's important to just be the best student that you can be and try to form those connections and relationships with mentors in dermatology or research mentors so that you're able to maximize the chances that you can have.
Yeah, for sure. And on this topic of research, Trinity has asked, during your undergrad or residency work, did you do any research dealing with dermatology? If not, or if so, what did you take away from that research in the lab?
Yeah, so since I did not know I wanted to go to dermatology, I thought I wanted to be a neuroscience major and do neurosurgery. I did neuroinfectious disease. So I studied Toxoplasma gondii. It's a neuroparasite. And I thought it was like the coolest thing. And I studied like anthrax. And so it's much more infectious disease oriented. The type of research that you do in college isn't always relevant to what you ultimately may do. We don't really expect you to do something that's relevant to your ultimate field of practice, but as long as you're demonstrating interest in research and as long as you're able to talk about it enthusiastically and talk about what you learned about it, even if you had a lot of failed lab experiments, that's still a learning opportunity for you to be able to figure out how to overcome that challenge and figure out if research is for you. Research is really heavily emphasized in dermatology, but not everyone that ends up becoming a dermatologist is a researcher. And so just figure out if research is for you. And if it is, that's great. If it isn't, then at least you tried and at least you could talk about it from an educated standpoint to say that you didn't like it for X, Y, and Z reasons.
So we're going to continue on with the role of education because Caroline Wong has asked, what extracurriculars were you involved in during medical school besides research and AOA? Any advice on how you found your niche within dermatology?
Yeah, so when I was in med school, I think a lot of my time was spent doing those research opportunities. Once you're in med school, it's really nice because research opportunities are kind of just thrown at you. It's really different from undergrad where you're like kind of, mass emailing professors and trying to say like, do you have a research opening in your lab? But once you're in med school, they're like, oh, great, like you're a med student, come along and like tag along and we'll just get you on this paper or like help us with this paper and project. So I did a lot of research. I was really like grateful to be having a great friend group around with me. So I played tennis a lot, enjoyed my time. I was speaking with a few people before, but I think that med school is actually easier than undergrad for numerous reasons. And before everyone is starting to gasp at me, but if you're able to go to a med school that's pass-fail, for example, it takes a lot of the competitive edge away. So you don't have to always be competing against your classmates right next to you. You can just, have fun, do the coursework, get a pass. We have the saying P equals MD in our schools. And so it's very much more laid back, but definitely it's still a lot of work, but it's more laid back compared to undergrad.
Mm-hmm. On this topic of undergrad, Shannon asked, what is the best major for medical school? She's seeing a lot of, but any major can be your major to be a pre-med. And so do you recommend that, or what was your kind of thinking behind going into neuroscience and then into medicine?
Yeah, so I think that in undergrad, unfortunately, there's a lot of pressure to be a science major, and that there's thought that like if you're not a science major, then admissions committees aren't going to look as favorably upon it. I can't talk about my official experience, but based off of my mentorship that I've had for students, I think that really you should do something that you're passionate about because it makes it a lot easier to get good grades in something that you're actually passionate about, whether or not it's in medicine. But as long as you do your cores and as long as you get the best grades in them for your requirements for med school, you can feel free to major in whatever you want. I find it much more interesting whenever I talk to someone who isn't necessarily a science major, but did well in their cores, and they could talk highly about why they really liked sociology or really why they liked art history. I think it makes it a lot more interesting rather than just talking about something that they may not be as interested in.
Yeah, going along with the topic of interesting conversation topics, Sais asked that she has a scribe position at an outpatient program. She heard that you were a scribe for Scribe America. So she's asking for advice on how to be a great scribe.
I think that being a great scribe, first of all, being able to type really fast is helpful, but I think it gets really tiring after time. But the best thing is being able to develop a relationship with the provider that you have, whether it's a physician or not, and being able to anticipate the next things that they'll be doing. And this takes a lot of time. So I was a scribe for about 6 months before I decided to just leave and travel the world and stop all the medical related things. But as that time progressed, when I was a scribe, I became very comfortable with the provider that I worked with. And even before he even started the assessment and plan, I was able already typing it up. Or sometimes you can even formulate dot phrases if you're that type of scribe and be able to use those as well. But developing that relationship with your provider and being able to understand what they're going to say next, what they have for expectations for you, and the different type of formats that they like, because everyone's very different in the way that they like their notes, is useful. And so getting that up front as a scribe is helpful. I don't think that you necessarily need to know everything about the medical specialty. That's impossible as a scribe. We don't really necessarily expect you guys to. But being able to be enthusiastic and being helpful and being able to learn the medical knowledge as it goes along is a really good skill to have.
Thanks for sharing that insight. And you mentioned that you took the scribe opportunity during your gap year. And so Hannah Razi has asked, what are some advantages of taking a gap year? Looking back, do you still wish you had one, or would you rather not?
Yeah, so I think taking a gap year is a very personal choice. For me, I felt that after undergrad, I needed a little break. I wanted to kind of beef up my application a little bit more in whatever aspect I was focusing on at that time. And I thought it was one of the best experiences I ever had. Going back, I would definitely recommend doing it. But everyone may have different experiences and different focuses. Some people may focus on volunteering. Some may focus on, improving their GPA or the Mcat. For me, it's just to improve kind of the volunteer experiences, the work experience I had. And the other component about what made it so great was that I was able to leave the country, and I studied in an Asian country, studied Mandarin for a while, and I was a bartender there. And so I developed a lot of otherworldly experiences just outside of medicine. And it was a lot of fun to be able to have that experience and come back and be very sure of my decision in medicine, having had other experiences outside of the world.
So we're talking about the gap year and how you spent it. But how are you able to balance all that with studying for the Mcat? Because Samantha's asked about tips on studying for the Mcat.
Yeah, so I think it's hard. It depends on when you're planning to take the Mcat. So for me, I took it between the summers of third and fourth year. So I was able to actually not focus on my classwork as much since it's the summertime and take it and study then. The Mcat's a little bit different now because I took the old Mcat and now it's a little bit more larger in terms of the amount of material that they're covering. But it took me about 3 months to study for, and then I took it. I self-studied. I thought it was a little bit easier for my schedule, but everyone operates differently. And so if you like a more formative kind of structured study schedule, that's good as well through the courses that are available. I think that ultimately, if you try to do it during the coursework that you already have during the school year, it's just about trying to figure out what time and where to place your emphasis on where you value your time. And as I mentioned before, it's important to study smart and not just hard, because passive learning, as we've all experienced in college and undergrad, isn't the best learning material and the best way to study. When I was in med school, I found that Anki is becoming a larger thing. And so if that is how you study, then I would encourage it. And that's how I studied in med school, and it worked out pretty well for me personally, but everyone's different.
It's going off the record, but I know before the session you were saying that med school to you was easier than your undergrad. If you could just talk a bit more about that, of what made med school for you, I guess, easier in your mind.
Sure. So I think that in college, I felt like a lot of times I was just trying to tick off a box, like, oh, I'm applying, I need to go volunteer, I need to do research, even if I really wasn't passionate about those things. And oftentimes I felt like a lot of my time and my efforts were wasted because I'd be sitting in a room doing some sort of volunteer experiences that really wasn't meaningful to me. So in med school, as I mentioned, all of that has kind of gone out the window. You're already gone past that point. You've been accepted to medical school. Research opportunities are a little bit easier to find nowadays. And if you're able to go to a pass-fail school, I just really wasn't as stressed out about my classes. I just studied, in the morning, and then I was able to go to the gym, hang out with my friends, and then we often studied together because we're no longer trying to compete against each other and trying to see who has the best grade. So we're able to just develop this more collaborative environment. At my med school in particular, we've had this large Google Doc in which we covered all the topics that would be covered in each lesson, and we collaborated together to make it so that you only have to do a fraction of the work compared to doing all of the work. So it was a lot nicer in med school that way. And I will say, lastly, that regardless of whenever you go into medical school, one of the largest things I tell all my mentees is that just because you're becoming a doctor doesn't mean that I should put a pause on your entire life. My gap year is an example. And even when I was in med school, I tried to make sure that I had a good work-life balance. Otherwise, you're just going to be burnt out. And whenever you're a physician, you're going to be even more burnt out, not able to save the patients that you really care about. So even when I was in med school, I took some time, like one of my friends was coming in from out of the country and visiting New York. And I was just like, well, okay, I want to make this time available. And so I studied a little bit extra or made some changes in my study schedule. I was actually just studying Anki on the bus. And then I went up to New York for a week, and then I came back and took my exam, and I did okay. So really just make sure that you're doing the things that you would try to enjoy otherwise if it wasn't for medicine, and don't just let medicine pause your life.
That was some very good advice. And if only undergraduate universities could be like that. Well, Emily has asked, how do you anticipate step 1 being fail affecting dermatology residency admissions? Will the prestige of your medical school matter a lot more or at all?
Yeah, that's a good question. So for anyone who's not aware, step 1 is a standardized exam that students typically take in their first or second year. Commonly, actually, they're taking it within their like 3rd or 4th year nowadays. But oftentimes in the past, that used to be make it or break it kind of deal for many students. They need to get a certain score to be able to be competitive in dermatology. And the exam was really hard. It was definitely one of the hardest exams I've ever taken. Fortunately, now they made it pass-fail to kind of remove that stress that is placed on students. But ultimately, just like the Mcat, schools will have to find something to replace it, to be able to standardize the assessments of students across the nation and across the world if they're international students. And so unfortunately, I think that it will be placing a lot more emphasis on step 2, which is a subsequent exam that's taken on later on in your med school. It is easier than step 1 in that it's more clinically relevant. And so you're not just learning about some minutia or some random facts. And if you get it wrong, then unfortunately that's what happens. But I think that dermatology and the competitive specialties and residencies will be looking at step 2 to find that, to be able to see where their student lies in terms of their competitiveness for that field. And then lastly as well, I think, unfortunately, a lot of times schools that do have a higher reputation or a stronger reputation do tend to have a better match rate. Not necessarily always the case, but once you're a student at that med school, it's better to focus on the things that you can control. As I mentioned before, once you're a student at whatever school you are, just try to be the best student that you can be. Focus on your research, focus on your mentors, and try not to just let that hinder you and have that effect of, oh, just because I went to this school, that doesn't mean I can't go to the specialty, because you should try. I mean, if you can't, then you miss all the shots that you don't take. So.
Yeah, and there sounds like a lot that you can consider when looking at med schools when you're deciding where to go. And so Hannah Razi has asked, when you were looking at schools, which schools did you find had a pass-fail? And then what other factors did you look at considering med schools?
Yeah, that's a good question. So for me, I was particularly looking at location first and foremost. I thought that I really wanted to be around family, and my family is near the Washington, D.C. area. So that was probably the first thing I really looked at. And then for me, the next few things were based off of 3 criteria that I commonly thought about. So first was whether or not the curriculum was pass-fail and how their curriculum was structured. Some of them have a lot more traditional approach in which you do healthy physiology first and then you do pathology second, but I liked integrated systems. And I like systems that were like more collaborative and did kind of reverse classroom. I like that style of learning better. And then secondly, I was looking for schools that had good research opportunities. And so for me, it didn't really matter which ones were the strongest as long as they had some sort of presence, because I thought I liked research, not as much now, but I thought I did it before. And then lastly, I was looking for a school that had a lot of international opportunities. And so whether or not we had the opportunity during our 3rd or 4th year to go abroad and to work in some sort of country that was foreign to me and exciting to me. And so those are the 3 main criteria that I looked for when I was assessing medical schools. And whenever we write secondary applications for med school apps, you'll see that almost all the schools have this why our school. And so before you answer that question, it's useful to have a framework in mind of what are you really looking for in a med school, whether or not it's location, whether or not it's, they have a great derm program there, or whether or not they're great in terms of having the international opportunities. So it's nice to have those set before you actually start looking and applying, because it can be a very expensive process as well.
We're going to be jumping from medical school to residency now, going in order. So our lovely audience member, Shebnem, has asked us, well, asked you, are you going to do your derm residency at UCSF too? I heard you apply for the prelim year and derm separately. So is it possible to match to only prelim but not derm, or to match in different states? Thanks for the presentation.
Yeah, of course. Hi, how's it going? So it is definitely possible to match at 2 different spots, and that's typically what's done. So you're right in that we apply to both a prelim program or first year program and the derm residency separately. So oftentimes people try to sometimes pick the same place in the same institution, the same school, but often more than not, we tend to pick separate locations. Me personally, I'll be going back to Georgetown in Washington, DC. I'm just out here on the West Coast for fun and to experience what the West Coast is like before I'm moving back to the East Coast. But it's oftentimes than not, it tends to be separate. There's some places that if you apply for their dermatology program, more often they will actually encourage you to apply to their 1-year program before, just for simplicity's sake, that you could stay there and be a resident there for all 4 years. And some of them actually encourage you to do it, and some of them will facilitate your efforts to do so and reach out to the program and say like, hey, this is a derm resident that's coming in, should we like to stay here, can we try to have her here? So they'll really vouch for you.
And continuing on the medicine path, Rihanna has also asked, is fellowship specific to surgery, or is it generally needed to be a dermatologist as well?
Yeah, so that's a good question. So for fellowships, they're not absolutely required whatsoever. So once you finish 4 years of dermatology residency, you can start practicing whatever you'd like. Fellowships tend to be required if you need to do Mohs. And sometimes if you want to do some sort of cosmetics, it's typically really helpful, but it's not always required. It's just something that if you'd like to get further specialization in.
Shannon has asked the urgent question about money. So what kind of financial aid can we get for medical school or for residency? We get grants to pay for the tuition. Is it the same as undergrad?
Yeah, so unfortunately, medical school could be one of the most expensive investments that we have. There are definitely financial opportunities available for scholarships once you apply to medical school, or even when you're in medical school. We had like monthly emails every single time about a variety of different scholarships that are available, ranging anywhere from a few thousand to a few hundred. So there's definitely a lot of options out there. Some students also like to pursue military options in which they're able to afford and pay for all of the undergraduate and medical school expenses, which is also another option if you'd like. But there is definitely an abundance of it. I know that overall, unfortunately, the average student debt is like anywhere from $200,000 after medical school. And so there's a variety of different ways to pay that back afterwards. There's a public service loan forgiveness program, which is some program that we're able to do if you are affiliated with a nonprofit or hospital, which is almost all the academic hospitals, after med school, and you do that for 10 years and you work with them, all of your loans will be forgiven after that 10 years. So you don't necessarily need to pay back all the 200,000. The only caveat is that you have to work with that affiliated program, but there's many of them. And it also includes residency. So if those 4 years of residency already count. So if you really like that program, you really like that hospital, just work there for 6 years and then all your loans will be forgiven already.
Wow, that's quite the journey you can take. And it sounds like you yourself are kind of like at this cool part of your journey as well, being a PGY1. Where do you see yourself in 5 years and continuing with your medicine journey?
Yeah, so that's a great question. So 5 years from now, I'll probably be in my first or second year out of dermatology residency. So for me personally, I have much more interest beyond just dermatology and clinical practice. I'm much more interested in entrepreneurship and kind of the technological innovation. So I would like to hopefully be either part-time derm or maybe full-time derm, but focusing on those sort of other kind of entrepreneurial pursuits. And I also really like teaching, obviously like coming and giving these sorts of talks. And so hopefully I'll be affiliated with some sort of medical school and having students come through to provide medical education about dermatology. But I'm really interested in a lot of different things like consulting. It's really nice once you have your MD degree that you're able to do consulting for other sort of companies. And for example, I used to do consulting for a nonprofit to open a hospital in Vietnam. And so that was something I was really passionate about, using your degree to do other things, not just in a clinical context.
You gonna ask the next question? Otherwise I can.
So I was kind of speechless by that because I'm Vietnamese. So I was like, Vietnam, okay. Uh, so just reflecting after your presentation, what last words do you want to leave with the audience?
Yeah. So I think that it seems like there's a really long road ahead, and that you need to do everything right, and you need to be the best student. And if you do this thing wrong, then you're never going to make it and become a doctor. And I would definitely say that's not the case. Everyone's human, and everyone makes mistakes. And so even if you fall down, just pick yourself back up and try to be stronger after it. There's a lot of things that will come up, including Mcat, step 1, step 2, step 3, which I just took. So there's a lot of exams as well. And so always be, passionate about learning. Make sure that you have a good friend group and support group, because things can be really hard. And sometimes without them, it's really more difficult to motivate yourself. But ultimately, regardless, whatever specialty you choose, whether or not it's derm or orthopedics or whatever, as long as you're happy about the kind of doctor that you are, it's great. And like I said before, you can really make your own practice whatever you want it to be. Just because you're a dermatologist doesn't mean that you need to see acne all day. If you're a dermatologist, you can even just do like consulting and open up curology, for example, and do a lot of different things outside of using your degree and something that you're passionate about. So don't just get fixated on one thing, but continue to pursue your passions, and wherever your heart is, it will take you. So that's great.
That is really sound advice, and we really wish you all the best in your continuing journey with all your different passions. And thank you also for presenting today. We really learned a lot. I saw a lot of nodding heads and lots of interesting questions in the chat. If you can, again, get your contact information if you want to reach out to you with any further questions. I'm sorry we didn't have enough time to go through all the questions in the chat today.
Yeah, no worries. You guys can just find me on my Instagram, Dr. Ben Tran, or my email. Hopefully the leadership here can share it as well. It's contact Dr. Ben Tran.
Okay, yes, we do have it on the presentation. That's great. Yeah, so thank you so much, Dr. Tran, for this wonderful presentation. My students will do a quick wrap-up presentation. Dr. Tran, if you want to head out of the call, you're welcome to do so, or you can stick around.
All right, thanks.
All right, my students. So thank you again for joining us today at Pre-Health Shadowing. I hope you learned a lot. And to help you kind of reflect on what you learned here today, we have 3 reflection questions for you. What brought you to today's session? What are 3 major takeaways that you got from this presentation? And what do you want to learn more about? The writing or reflection is not required. However, we encourage you to submit this to our website for publication and recognition of your hard work to enhance it for your future applications. You can do so by submitting any written pieces at www.prehealthshadowing.com/blog submissions. The link should be in the chat. And if you want to learn more about pre-health shadowing or get more involved with our program, we learned a lot about volunteering and teamwork today. We encourage you to visit our website where you can become an asynchronous volunteer to get certified volunteering hours through professional nominations, grant writing, and other fun things. I also saw some current volunteers in this Zoom chat today, so nice seeing you. I hope to see more of you soon. We're also accepting applications for team members. If you want to get a more active role and lead projects within our organization, we are welcoming you to our team. We once again are humbly asking that if you're financially able to donate, that you please consider sending a few dollars via Venmo or PayPal. It costs a lot to keep our program up and running and free for everybody to attend these Zoom sessions, as well as other initiatives that we're putting forward. So if you or someone else can afford to donate $1, $3, $5, whatever you're able to, we humbly ask that you're able to help support us by using this QR code. You'll be asked to join our donation team. And yeah. Okay, now for the part we've all been waiting for, earning our verified certificate for the shadowing hours we got here today. So the first thing you're going to do is go onto our website at www.prehealthshadowing.com. You're going to search for Dr. Benjamin Tran on our website. You're going to, once you find his course, you're going to hit take this course. From there, you're going to have the option to take the quiz. It'll open up at 2 p.m. Eastern Standard Time, 11 o'clock PST time. So you might have to wait just a couple more minutes for that to open up. You're going to answer the quiz, which is based of 10 multiple choice questions based on the presentation we had here today. You have 2 chances to pass with a 70% or higher. Our quizzes are open indefinitely for your convenience. Once you start the quiz, as you can see here, you have about 30 minutes to take it. Once you have passed the quiz, you're going to hit finish this course, and then you'll be able to download the certificate from there. If you have any questions or run into any issues in this process, feel free to email us at info@prehealthshadowing.com. We know that our website is a little funky, which is also why we keep asking for donations, because we do need to keep that funded to keep it running. And if you missed any part of today's session or you want to rewatch it, you're welcome to visit our YouTube channel at Pre-Health Shadowing. You can watch any of our previous sessions for free, as well as take the post-shadowing session quizzes for those sessions and rack up your shadowing hours. Be sure to catch us for our future sessions. We have sessions booked all the way through June, and we are so excited for all the professionals we have on board, and we're excited to see you there. And I think, oh yes, this is also another initiative that we're hosting for Women's History Month in March. If you can join us on March 27th at 9 a.m. PST, or March 28th at 10 a.m. PST, we are having a Women's History Month panel with exclusively feminine disparities in healthcare's perspectives from real women professionals. Our Chief of Diversity, Aster, who's also in this call, has worked very hard on putting together this panel for you guys. So feel free to use this QR code to reserve your seat, or share it with your friends who might be interested in learning more about women's health and celebrating Women's History Month. Yep. And so this is concluding the end of our session today. Thank you for joining us. Feel free to stick around if you have any questions for myself or other teammates. We're happy to answer them. This shadowing session is officially over. Feel free to disconnect from the call and have a wonderful day. Thank you all so much for joining us.
Thank you.